Uh, Okay, so good evening, everybody, and good evening, everybody, and thanks for joining in. Today, we are actually really honored to have Dr. R. Suresh Kumar with us, and Sir will be talking to us about moments of truth in managing congenital heart disease, to do or not to do. We are also blessed today to have an elite panel, expert panels with us. We are actually very thankful to Dr. Jagan Mohan Tharakan sir for joining us, and we have Dr. PV Suresh sir from Bangalore, and of course our very own Manoj Kumar Rohit sir, who is also gracing this occasion. So, without much ado, over to you, Dr. Suresh Kumar sir. Uh, Thank you.
Thank you, Dr. Smith, and good evening to my dear friends. As we grow older in the practice of a profession, you can't help becoming a little philosophical and wonder at times whether whatever you did was always right or not. That is why I've chosen to speak on this topic. While managing congenital heart disease, I've compiled some of the instances where I really hesitated whether to do something or not to do something. And I'm not certain, or certainly in some instance, I'm certain that I didn't get it right. I would dedicate this talk to the memory of Professor Bidwai, who stimulated people like me, Dr. Jagan, Dr. PV Suresh, all in the pursuit of pediatric cardiology. He was truly our guru. In these instances where the guidelines do not tell you how to deal with the specific situation at hand, it's knowledge, skill, experience, and pure luck that would decide the outcome. I'm illustrating some of these instances. To begin with, let's start with something simple. You have an ASD in a patient above the age of 60. Right now, I had a 54-year-old woman. What would be the problems quite different from, say, a 10-year-old or even a 30-year-old patient with ASD? Above the age of 60, they're very likely to have a comorbidity. Diastolic dysfunction of some degree is inevitable. Atrial fibrillation is common. Some degree of pulmonary hypertension is common. So you need to know when it is better to stay away from the patient. And if even if none of these are there, we also need to ask ourselves the question, are we doing any good to the patient by putting a device in a hole which has been there for 60 or 70 years? Not to mention the technical problems that a large ASD, atrial fibrillation, or intra-procedure arrhythmias would pose. This is a 30-year-old woman whose diastolic function evaluation is on the screen. This is fine. The E by A is 1.7 and the E by E prime is 10.6. It can't be the same way in a 65-year-old woman with a 12 millimeter ASD. Obviously, the A wave is higher. The E by A is only 0.7. And the E by E prime, you can see, is 15. And we have data to suggest that the E by E prime more than 15 millimeter would denote an elevated LVEDP. This patient may not tolerate a device closure if you do it just abruptly. And it is in such patients that acute left ventricular failure could occur after ASD closure. There are multiple reports of that. And especially in this age group and in presence of systemic hypertension, you must be anticipating pulmonary edema if you close the ASD. If you do a test balloon occlusion, I do a test device occlusion, and pharmacologic preconditioning with diuretics and vasodilators can avoid the complication. Some people have suggested that a baseline LVEDP less than 15 or balloon occluded LVEDP less than 25 would suggest that the patient is likely to tolerate it. I'm not sure that it works always that way. Look at this 59-year-old woman who had poorly controlled blood pressure and class 3 effort dyspnea. She presented with LVH and diastolic dysfunction and with a 14 millimeter second MASD. Aware that this patient is potential trouble, I controlled her aggressively, her blood pressure, with valsartan and atenolol and chlorthalidone, and took up for ASD closure 3 months later. The device is in position. The LVEDP is being monitored. It's quite low. This is the 25 line. So you're way below it, and it is safe to close it. And sometimes it doesn't work this way. A recent patient whom I had was a 57-year-old lady, uncontrolled diabetes, uncontrolled essential hypertension. She was a psychiatric patient on multiple drugs with a history of recent onset effort dyspnea and a 28 millimeter second MASD. Uh, I wanted to catheterize her first. She had a septal E by E prime of 19. And in the cath, the LVEDP was 25 as dressed. So I didn't proceed to closing the ASD. Normal, her coronaries were normal. She was treated, and her E by E prime never came down. So I suggested to one of my colleagues in another hospital to use a custom-made fenestrated device, and they planned to do it. But as it quite often happens, the device did not materialize. So they actually closed it with a 30 millimeter LifeTech device. Patient was intubated and ventilated. The LVEDP was 32 millimeters of mercury after device closure. The patient was kept on ventilator for 48 hours on an infusion of Lasix and Milrinone, actually, and extubated after 48 hours, kept in CCU for another 2 more days, and the patient was discharged on diuretics and vasodilators. This patient is actually doing well now. This is her echo last week. You can see that her E by E prime is now 12.5, and the E by A, of course, the A is much taller, but she is symptomatically a lot better. And 3 months post device closure, this is what the ventricles look like. The RARV are not terribly enlarged. The device, large one, is very much in place. Moving to another issue of ASD in adults is PAH. And the here the standard guidelines now would say that a QPQS more than 1.5:1, a PVR SVR 0.2 to 4, 0.4, you could go ahead and close, but they do not predict long-term outcomes. In fact, there is a paper by Dr. Taragan and Dr. Soni, your resident, shared this with me some time ago. 20 patients were surgically treated for ASD with a PVRI more than 4 Wood units. More than half the patients had no decrease in PVRI at follow-up cath 6 years later. So the decision really needs to be individualized, and perhaps fenestrated device closure and targeted PAS therapy may be an option, or perhaps you could just leave them alone. And what do you do when there is atrial fibrillation? Data suggests that the outcome of device closure is as good in patients with atrial fibrillation and in those with atrial fibrillation. So one will go ahead and do it. This was a patient that I had seen in Muscat, a 65-year-old Bedouin, they are nomads, patient with hypertension, diabetes, and dyslipidemia. This patient was in atrial fibrillation. The cath showed that there was a chronic total occlusion of the mid-LAD, which is well collateralized, so we didn't need to address that. The LV pressures were 130 by 15, and the PA was 43 by 20, a mild PAH, 31 mean. And he wouldn't take anticoagulants or antiplatelets. So we closed the LA appendage with a Watchman device, which was an easy thing to do with a large ASD. And then we went ahead and closed the ASD with a 34 device. The post-device CDP was 20. Patient was put on dual antiplatelets. I'm not sure that he took it, but fortunately, 3 months later, the T didn't show any clot. So this type of situations can arise. In this, you can see the large ASD device being deployed with the Watchman device in the horizon. The basic question, does it help people above 60 years if you close? There is data to suggest that their symptoms improve, there is improvement in exercise capacity, and the right heart does remodel. So this is a 70-year-old lady, 1 year after ASD device closure. And you can see that the RA-RV are practically normal. And we had checked this in a small series of 5 patients, all between 60 to 70. The decrease in RVID and increase in LVID did happen, and the diastolic function improved in all of them. I started with ASD because the problems are familiar to a larger number of people. But our problems begins in fetal life. When you deal with a fetus, and increasingly we deal with a significant number of them, one of the fundamental questions that we need to answer is whether we are going to encourage termination of pregnancy or continuation of pregnancy. In instances like a heterotaxy, right isomerism, as you are seeing on the screen, with a pulmonary atresia and usually associated with a TAPVC, not shown here, the mothers usually want to terminate pregnancy and you can go along with it, but their prognosis is uniformly poor. But however, in some instances, we are caught. This was a second gravida mother in her 20 weeks pregnancy. Her fetal echo done, I was in Chennai when this patient had presented. The fetal echo had shown pulmonary atresia with intact septum. And in another metro, she had been recommended termination of pregnancy. Very educated mother. She wanted to continue and wanted encouragement from me. I put trust in the ventricle's anatomy. It was a tripartite RV. All the parts looked a little small, but I thought there was a fair chance that if this baby is born with valva pulmonary atresia, we could do something to it. But as luck would have it, this lady went into a spontaneous preterm delivery and we got a 1 kg baby at 28 weeks. This would have been in 2009 or 10. We didn't do anything. There was a large PDA that began to close by 6 weeks. At 6 weeks, at a 1.5 kg weight, we did an emergency surgical pulmonary valvotomy. I was not sure. The surgeon was less sure whether this baby is going to survive and how this baby would behave. We could discharge the baby with an 80% saturation, which slowly limped up to 90%. 3 years later, I had a cardiac MRI done. You can see that the RV, which is on top of the image here, is better. It is muscular, but it's better. And if you see this RV, you get better confidence. And when you look at the absolute values, I would thank my friend Dr. Jebiraj for giving me these MRI images and calculations. The RV dimensions, systolic and diastolic, are just at the lower end of the spectrum of normalcy. So this baby grew up, did well. She had 2 RVOT dilatations. She had an ASD device closure because she was desaturating because of right to left shunt across an ASD. Now at 14 years, she saw me a few weeks ago. She's a bright, shy school student, quite intelligent in Bangalore. From the fetus, if you move to the newborn, this was a problem which I encountered in Muscat. There was a term baby who came with severe cardiac failure in the 3rd week of life. And the child had a dextroposed heart in cytosolitis. And clinically, there was evidence of pulmonary hypertension. And the investigations showed that there is a cytosolitis dextroposition. There was only a small second MAST with bidirectional shunt as a structural lesion, but the right inferior pulmonary vein was draining to the inferior vena cava. And there was a collateral artery from the descending aorta to the right lower lobe with evidence of severe PAH. We all know the diagnosis, scimitar syndrome. And scimitar syndrome is rather common in the Middle East. And we used to see at least 5 or 6 scimitar syndromes in younger age groups in every year. This shows the scimitar vein. You can see the right inferior pulmonary vein, which is coming into the IVC-RA junction. And on this side of the screen, you can see the collateral artery to the right lower lobe. And we have put an ADO2 device to block it. So we thought that the patient would benefit. Patient severe pulmonary hypertension must have been due to severe volume overload because of the collateral. But as it happened, that didn't happen. The baby continued to have severe PH. The baby could not be extubated. And in the next couple of weeks, the baby had recurrent lung collapse and septicemia. And as these issues settled, it fell on my lap to restudy this baby. We found that the PA pressures were systemic, and the descending iotogram showed complete occlusion of the aberrant vessel. There was no additional collateral, but the RPA lower lobe branch. I'll go to the next slide before I come here. Please, this is a single movie image. If you watch this, you will find that there is a selective injection into the right lower lobe pulmonary artery that is leading into a fistulous communication with the scimitar vein. So this is a pulmonary AV malformation, a large one connecting the right lower lobe regular pulmonary artery to the scimitar vein. We could close this with an ADO2. And this side of the image shows that at the end of the image, the flow is completely occluded. There was a small PDA. We didn't want to take a chance. We put a coil there and closed it also. And what happened? This was the pressures pre-closure. You can see that the aortic and PA pressures are same. And the catheter slipped into RV when this was being recorded. So the RV pressures, RV systolic, is less than the PA diastolic pressure. So the pressures have significantly dropped. We had presented this as a presentation at the CSA Frankfurt some time ago. Moving from this to another problems where you may not be very sure how to deal with are when you encounter coronary problems in children. I'm not speaking of, say, an Alcapa or a coronary abnormality that comes with a TGA, but something that defies definition. Or even a coronary artery fistula, like this is a left sinus to RA fistula in a 20-year-old, which could be easily closed. But what about this? This is a 3-year-old child with pulmonary atresia, intact ventricular septum. The child had been managed as a newborn by a ductal stent. And at 6 months, the child had a Glenn operation. And at 5 years, I had to study this child for a pre-Fontan cath. The child was in congenital complete heart block. The ventricular rate was 50 beats per minute. Look at this image closely. It's a hand injection through an RCA catheter. So you may not see very well in this, but I would point out that the injection in the RV from the RCA catheter tip is leading to a fistula, the details of which you can't see here. You can certainly see a faint outline of the aorta. And in this lateral view, you can see a little more of that fistula. That fistula is better outlined from the LV. You can see that the right sinus is hugely dilated, and the right coronary is coming from that. And that is the aortic end of the fistula. The RV catheter is still there. We put a balloon in the fistula and see what would happen if you try to occlude it. There was profound ST depression in the inferior leads, thereby demonstrating that this baby has an RV-dependent coronary circulation. Just to recap on coronaries and RV coronary communications in pulmonary atresia intact septum, this is a peculiar problem when you deal with this entity. There is a high pressure RV from the fetal life with valvular pulmonary atresia or any form of pulmonary atresia with intact ventricular septum. And therefore, the myocardial sinusoids, which link up to connect with the protrusions from the aortic root to form the coronary arteries, they start shunting from the RV into the coronary artery. And the proximal coronary arteries quite often are atretic. This is more likely to be seen in a small RV. The smaller the RV, say like a bipartite RV or a unipartite RV, you are more likely to see this fistula. So remember, this case had been taken up for pre-Fontan cath. Can we go ahead and complete the Fontan? If you complete the Fontan, the RV is empty, but for the coronary sinus blood. and the patient is very unlikely to tolerate it. Indeed, the recommendation is to send this child for a cardiac transplant. In Oman, we did not have facility for cardiac transplant. Okay, we are not doing Fontan. Now, can we treat the complete heart block? Because the child has a rate of 50. Why not? At least we can do something for the patient. Uh, so we gave the child a surgical epicardial VVI pacemaker. Mind you, the SVC was going into the PA. We couldn't do a percutaneous pacemaker implantation. So we gave an epicardial VVI pacemaker and implanted surgically. And we thought that we were very smart. And what happened? 4 hours after the procedure, after the surgical procedure, baby had been shifted to the cardiac surgical ICU. The baby developed an arrest and died. I would have presumed that the rate of 80 was not tolerated by this vicious coronary system, which was used to a rate of 50 per minute. So we harmed the patient. But these sinusoids sometimes can be there as benign structures also. This image was shared with me by my former trainee, Dr. Pulshan Chavan in Bombay. You can see that this is actually a critical PS. It's unusual to find sinusoids in this setting, but there are sinusoids leading away from this RV, but there is antegrade flow, which encourage Bhushan to do a balloon pulmonary valvulotomy, which of course will not maintain the saturation. So he did a stent and a ductal stent, and the patient did well. So sometimes the sinusoids, given antegrade flow, the RV is already decompressed, are not leading to RV dependent coronary circulation. And then you can deal with these like normal critical PS. We had a very bad experience recently. I told you the focus of my talk is that the decisions that we take are always not correct. Now, this is a boy who was rather personally close to me. He had been under follow-up in my current center in Tiruvalla for bicuspid aortic valve. Over years, he developed progressive aortic stenosis and ascending aortic dilatation. Early this year, when he was 14 years of age, he had features of severe aortic stenosis, and his ascending aorta was 5 centimeter in diameter. So he underwent a Bentall operation. He had a 30 millimeter Dacron graft, and a Chitra valve has hand sewn onto it, and the coronaries were transferred to the graft. While he was coming off bypass, the RCA appeared stretched. So the surgeon gave a venous graft to RCA and could come off well without any problem. The child did very well, and he could be discharged in 2 weeks. But 2 months later, he was playing football with small children, but he had an exertional syncope while playing. He recovered and came okay to the OPD. I put him on the treadmill, and he showed a 4 millimeter ST depression after only 2 minutes in stage 1. I did a CT angio, which showed that there was a tight lesion, maybe an extrinsic compression on the left main coronary artery. We wondered whether it was a surgical glue. He was taken for coronary angio, and the moment my adult colleague put a wire across it or tried to wire it, he started getting VTVF, and that just will not go away. So we did not have an ECMO circuit on that day. So we put him on a percutaneous cardiopulmonary bypass, and the left main was stented with a Synergy Megatron stent. This is the pre-image. You can see the tight left main lesion. The encouraging thing here was that this was very readily dilatable and without event when the patient was on bypass. And my colleague produced an excellent angiographic result. You can see that the left main had opened up very well, and he has a near normal coronary system now. But what happened? While decannulating, he developed bleeding. And while the bleeding was controlled, his VF returned. He had a prolonged resuscitation, and eventually he succumbed. We thought we won the battle. We certainly lost the war. But we don't always lose our critically ill babies. There's one instance where a baby with a blocked BT shunt with chest compression is undergoing a recanalization, a recanalization crossed with a coronary wire and dilated with a foramen balloon. So we do sometimes achieve what we set out to do. From this, uh, I would move to some of the vagaries of coarctation that we do. I must mention before I move on that pulmonary atresia intact septum, like scimitar syndrome, is very common in the Middle East population. In fact, in a meeting, I had pointed out that in Muscat, National Heart Center, where I was working, we used to get something like uh, 60 cases of pulmonary atresia intact septum in a single year. And Dr. Shakil Qureshi had told me that in UK, with a population which is much higher than that of small Oman, they see about 35 cases in a year. So pulmonary atresia intact septum and its problems are rather common in the Middle East population. Now moving to coarctation, balloon dilatation for coarctation, for recoarctation in infants following coarctation repair is a very common thing. Again, in the Middle East, coarctation in some form or other we encounter very frequently, so that every year we see maybe something between 50 and 75 coarctations, either isolated or as part of a VSD or TGA or something like that. And we know, everybody knows how to deal with it. And just to highlight our numbers, this was a presentation that we had made in the World Congress in Barcelona from Muscat. This is 35 cases of infant coarctation, balloon dilatation. The 25 of them were recoarctation after surgical repair, but 10 were native coarctations. They generally do well. But that does, and this is one such instance where fairly straightforward, discrete coarctation, a 3-year-old child, the response to balloon is excellent. But look at this. Since this is single running image as a movie, you'll need to see closely what this patient has got, or how the patient came to me. The surgeon had seen this patient, referred from somewhere, and the case had been sent for coarctation repair. He called me and pointed out that the child had differential cyanosis. The child's lower extremities were blue and had a lower saturation. So that is how I came to see this child and study this child. So this child, you can see the ascending aorta is very hypoplastic. You can see in the beginning of the image that the ascending aorta is rather small. Aortic valve and ascending aorta are small. Arch is okay, but is followed by a tight coarctation. And then the descending aorta is normal. Now, how does the circulation go? You can see that the RV is going into the pulmonary arteries. The pulmonary arteries both have a tight stenosis at the origin. And there is a large duct which is connecting the pulmonary artery to the descending aorta and shunting right to left. And my marker is on an aneurysm of the duct. So there is a large aneurysmal duct which is shunting right to left. And that is why this child had differential cyanosis. So I suggested that nature has done a hybrid Norwood in this child. In a hybrid Norwood, you band the individual pulmonary arteries and use a large stent to let the duct stay as a conduit. So this the nature has done. At 3.6 years, the child was undergrown, 9 kg, differential cyanosis, but otherwise okay. What do we do here? I felt that perhaps we can see what happens in response to the coarctation stenting. So we put a Cook formula 8 millimeter stent for relief of coarctation, preserving the ductal flow. There's a residual gradient. Now you can understand the anatomy a little better. I have a catheter in the PA. It shows both the PA branches which are tightly stenosed. It also shows the ductus with the aneurysm. But the flow is still right to left across the duct. My stent did not encourage much forward flow. He lived 3 years. Then one of our surgeons felt that he could repair this, and the child died during attempted surgery. Working with surgeons has been generally a pleasure for me. I've worked with some of the finest surgeons in the world and in India. And in some instances, we actually work with them in the cath lab or in the theater. We had this baby with a truncus arteriosus. This truncus arteriosus was an unusual one in that Dr. Rohit would recall the current classification by Anderson of a truncus is as pulmonary dominant and aortic dominant. And the pulmonary dominant trunk is usually associated with a coarctation or aortic arch interruption. This was a child with a pulmonary dominant trunk without aortic arch interruption. Aortic arch is a little small but was okay. And so this child could undergo a repair using a Contegra conduit. But he developed progressive bilateral PA stenosis by 10 months of age. Dealing with that was a problem. Now, actually, we published this from Tiruvalla. Dr. Anderson was kind enough to join us as an author. And this is the pre-op situation. Here is the trunk. Here is the aorta arising from the side of the trunk and looking much less impressive compared to the main pulmonary artery. And this is after repair, 3D reconstruction. Look at the continuity of aorta and seen from behind. This is the conduit with the two pulmonary artery branches coming off it. Everything looked well at 3 months of age. But at 8 months of age, this was the situation. You can see that both the pulmonary artery branches are stenotic, and the left one has a proximal tight stenosis, and the right one has a long segment stenosis. And the child's RV pressures were systemic. This was a 10 months, 7.3 kg, cath showing systemic RV pressure, unobstructed conduit. And this was the CT pulmonary angiogram that I showed. The problem here to address this in the cath lab in such a small baby, stenting both the pulmonary arteries in the cath lab, I certainly do not have the skill to. So we devised a plan. Look, the RPA is under the aorta. If the surgeon is to repair it, he will have to transect the aorta. So he asked whether that can be dealt with interventionally. The LPA is right under vision, and therefore that could be dealt surgically. So what we did was the surgeon did a reduced anatomy, cardiopulmonary bypass on a beating heart. The conduit was opened above the valve, and the incision was extended to the left pulmonary artery, and this was enlarged with a pericardial patch. Through that hole in the pulmonary artery, under vision, we could pass a 4 French JR catheter leading with a Cook Roadrunner wire, and I stuffed that wire in the hilum and used a 7 mm into 2 mm Tyshak 2 balloon positioning under direct vision, pre-dilated the lesion at 4 atmospheres. It responded easily. And then a balloon mounted 8 into 2 Cook formula stent was passed over the wire and deployed at 8 atmosphere. The position was checked manually and then confirmed on epicardial echo. We do not have a C-arm in the theater. And this child is doing well at 5 years of age and is an excellent illustration that even in small children, a little thoughtful interaction with the surgeon can give excellent result. I thought this was worth documenting. So this was the stent in the RPA, and you can see that that rotational image shows the well opened up RPA and LPA. But it's not that you can always share the work with the surgeons and do it. You have to bow to their skill. And when you feel that that is in the best interest of the patient, and in congenital heart disease, what saves lives are surgeries. This was an only child of South Indian parents. I'd seen this child in Chennai. Child had a neonatal balloon aortic valvotomy for severe aortic stenosis, and later a surgical repair of coarctation 2 months later. And I had for the recoarctation, I had done balloon dilatation at 6 months and 2 years, and she was doing well. At 4 years, she had a stroke. We actually do not know what happened, when perhaps she had a viral myocarditis, because this child who was doing well, when she came to me with the stroke, had a very poorly contracting ventricle. She recovered only partially from that. At 15 years, she saw me in Tiruvalla, where she was hypertensive. The upper limb blood pressure was 160 by 100 with a lower limb of 80. And she still had an LVEF of 45%. She had a transverse arch hypoplasia and a long segment ischial hypoplasia. If you see here, you can see that the transverse arch is small. There's a very long isthmus, if you may call so. And you can find that the LV ejection fraction is depressed. We debated a lot as to whether to give this child a long stent, which would be expensive for this child also. The surgeon offered to do a ascending to descending aorta graft. Actually, it worked very well. She's doing very well now. So this was an excellent experience of a fairly simple surgical solution to a complex problem and the child doing well. I would also say that many instances where my generation has hesitated, next generation has gone forward and produced excellent results also. Some of these I may not do, but I would like to project. The two cases that I'm showing are both from my dear resident, Dr. Bhushan in Bombay. This is a 25-day-old baby, 1 kg, on ventilator, PDA. They failed pharmacologic closure. I would have had this child undergo a surgical ligation of the PDA in the NICU itself, but the younger generation wouldn't accept that. And what did Bhushan do? This child had no femoral venous access. He found the access from the jugular and closed this with a piccolo device. And he also shared me the current pictures of this baby. This baby was extubated in 48 hours. The baby was in renal failure before. Its parameters improved. It was discharged in 2 weeks, and 3 months later, it's a sweet kid. Also, this is a 15-month-old baby, 6.5 kg Down syndrome, long tubular PDA. I would prefer surgical ligation, but not Bhushan. He put in and he actually tried with an ADO 1210, which is beginner, and a AVP2, and both came through. And he actually used a 1412 PDA device, a Merrill PDA device. This is the iodogram after that. I'm not fully happy with it, but 2 months later, the pulses are okay and the pulmonary are okay. So our younger generation is carrying the pattern forward and much faster to new destinations. So I would conclude here to say that the practice of congenital heart disease, which I have enjoyed, involves asking oneself basic questions regarding the appropriateness of one's management plan. And we will try to do the best, keeping in mind the patient's interest uppermost in our minds. And pediatric cardiology work is a teamwork. We need to respect your surgeon and anesthesiologist and listen to them. Thank you.
Thank you so much, sir, for all those wonderful cases that you have collected over a lifetime of work in pediatric cardiology. It's frankly a little bit overwhelming, I think, for me. Uh, but yeah, those are very wonderful cases. So we have maybe we can have some discussion. Maybe I'll start the ball rolling and ask the silly question first. So you'll excuse me if it is okay. So, like you were saying that you deployed that stent under visual in the
Yes,
truncal space. You
yes.
deployed that stent under visual direct vision. So, so how like from
How would you
basic
do that?
intervention, how do we
Yes,
understand the landing zones, the
yes.
length, and the
See,
diameter?
good question. I get the point. See,
Yes.
what we had done was, I didn't describe it in detail. We had done a CT angiogram earlier, and we had measured the stent length. And the stent length is measured from the RPA origin to the lesion. The RPA origin is visible. Since the
Yeah.
RPA origin is visible, as long as and I first tested with the balloon, not only to pre-dilate, but to test the idea that this is going to work. If a balloon will go there, inflate, then it can carry a stent there and keep it there also. So the stent length had been predetermined from the CT angio. And then under vision, we deployed it this way. And what gave me this idea is a case that I have done with KMC, where for a Norwood management, the hybrid Norwood, where we put a stent under vision between the PA to the aorta. And the surgeon banded both the pulmonary arteries. So I had this vast experience of one case. So I thought that idea could be imported here. And we did not have another, what should I say, workable way of dealing with this child. Unfortunately, it worked.
And the LPA was also dilated, sir, or the
No, no,
surgeon
no.
corrected that?
See, the difference between the LPA and the RPA, when you do the sternotomy, the LPA is right in front of the surgeon. So he has no difficulty in dealing with it. But the
Okay.
RPA is under the aorta. In a redo surgery, you do not want to transect the aorta and do that surgery if it is possible to avoid it. That was the logic why we devised this hybrid plan, and we didn't have the facility. We don't have a C-arm in the theater. So the plan was well worked out. I did an epicardial echo in the end to confirm it. While the child was being shifted, our cath lab is fortunately next to the theater. I went to the theater, to the cath lab, did a fluoroscopy, and found that everything was fine. But it was a little hair raising.
Yes, sir. Right, sir.
I must say it's a unique lecture. Only Dr. Suresh can do it because he has decades of experience of working with some of the greats and huge collection of wide variety of patients. The perspective he has brought to this lecture is completely different. We are used to these didactic lectures, you do this and that. But there is a thought which is there, which is what is right, what is wrong. So he has brought those nuances very well.
Thank you, Suresh. The basic point that I was trying to convey, you are faced I must take a step back and give credit to my surgeon, Dr. John. Dr. John has a famous saying. He's a very avid card player. He says
Okay.
that there are only 28 or 56 cards, but each time you are dealt a hand which is very different. So there is no point in saying that I can recognize all the 56 cards very well, but a given deal you may not be able to play. That is the beauty of congenital heart disease and managing it. Every case comes to you with some challenge, even if it's a simple ASD, you find that there is something new in that, which is one, intellectually provoking, and second, challenging your skill.
Yeah. And patients keep on teaching things. For example, this the counseling for patients with antenatal diagnosis of complex congenital heart disease.
Yes.
So this is a common problem now because one observation which I want to share is I'm not seeing heterotaxis. I'm not seeing even transpositions frequently now. They're all terminated. They don't even come for second opinion. The periphery radiologist will tell them पेट के अंदर सब उल्टा है, स्प्लीन दिखता नहीं है, हार्ट में भी सब उल्टा ही रहेगा, आधा ही हार्ट दिखता है. Moment they hear this, they just go to the obstetrician and terminate. So we are used to this heterotaxy with AVCD, AV valve regurgitation in the intra-uterine period. They have very poor outcomes. So invariably we end up saying इसमें तो कुछ नहीं हो सकता है.
Yeah.
But
I can show
some
you.
patients,
No, that's
I
true. I
want to
think
share a different perspective.
urethral echo
Yeah.
being very universal, especially in the East European countries, you don't see any complex congenital heart disease at birth. They're all
Yes.
terminated at
It is
age of
actually
2 weeks.
happening because I go to the periphery regularly And every month I used to see new complex congenitals 10, 15 years back. Now I don't see any of them. I
Yeah, that's
routinely
also coming to India now, because neonatal, fetal echo is so widely available that most complex congenitals, which are easily detectable at age, are detected at the age of 12 to 14 weeks. They won't
they're
survive
all
20 weeks.
Yeah.
They won't survive 20 weeks.
But Suresh, the other side of the story, in where I practice, which is the Central Travancore, which is an affluent region, there's a strong Christian population. Many of them are against termination. My
Yes.
hospital will not do termination. In my own center, in my own fetal medicine unit, we have had 3 TGAs diagnosed. All the 3 delivered. 2 of them had switched with us. One went to Amrita for switch. All the 3 did well.
Yeah,
Yes.
TJ is probably the only one which will survive the very
No,
dangerous.
no, I'm talking because I just started by
Yeah,
saying that
that
the
fetal
patient
echo
was
problems.
of a different perspective. This patient where at 16
Yes,
weeks
yes.
we diagnosed hydrotaxy. Mother was 40 and she had conceived after a lot of effort. She said from her perspective, it's okay if it survives only for 5 years or 10 years. It's okay with whatever I go through. I want to have the pleasure of holding my own baby in my own hands.
Yeah. And you can't
So,
fault her, no? It is
yeah,
after all her child.
Yeah, no,
we
that's
grew
true.
up a different perspective. We
Yeah,
are routinely used to saying, look,
absolutely.
this intro taxi is bad. You'll have hospital back and forth, back and forth. We can't do anything. We
Yeah.
just raise our hands and say we can't do anything. And it's so frustrating when you see that child suffering, mother, parent suffering, and you feel, अरे पता पहला ही पता लग गया होता तो ये सब झंझट ही नहीं होता. यहाँ पे सब कुछ पहला ही पता है, but mother says no.
Yeah.
So this is a different perspective
Yeah.
which the parents and family can throw up.
So, Suresh,
There is a question in the.
Suresh, this is Dr. Claire. Am I
Oh,
audible?
Yes, sir.
Oh, Claire,
Yes, sir. Yes, sir.
Claire, when did you join?
I'm sorry, my picture is not coming. Maybe rightly so because I'm an old man. They don't want to show my
No, I
face.
certainly mind. I want to see you.
Yeah, there's some problem here. I don't understand that.
Okay.
But great to see you and Jaganmohan and Sujatya, and of course our blue-eyed boy Smith Srivastava. You have all connected all of us, and it's a great pleasure to be part of this family. I always call PGI is a family. It gives me so much of a thrill and enthusiasm and affectionate feeling anywhere I meet PGI person. So great, Samit. Again, I want to thank you. And the thing, Suresh, I would like to say is that it is a pity that in our country, you get sometimes, many times, you get to diagnose congenital heart disease at the age of 70, which is very painful. So, in my opinion, what should be the policy in the nation that every newborn child born should be examined by cardiologist, preferably by a pediatric cardiologist. I know pediatric cardiologist is not available everywhere, but even a cardiologist examining, and if there's any murmur or things of that nature, they should be taken care of. And then the second phase where the every children should be had a cardiac checkup when they go to school, at the age of 4 years or so. When the school entry, it should be mandatory for a routine cardiac checkup, because by the time your child is 4 or 5 years old, I think the chances that you will miss the congenital heart disease are very, very low. So there should be some kind of a national policy to screen for congenital heart disease, which is not existing in our country. And when you see a BSD or atrial septal defect coming with isomagnetic complex, the girl is 19 or 20 years old, and they want to marry that girl, you are very pained to see what is happening in this country. I don't know what your suggestions are, but I'm not a congenital heart disease specialist, but still patients come to me, and I feel very bad that if it was some kind of system in the country to detect the disease early on, they could have, we could have prevented all that catastrophe.
Claire, it's a very valid point, but I'm very happy to tell you that there is effort in this direction in the country. Now, Kerala has gone a long way forward in this. It's part of a national program, see what is called the RBSK, the Rashtriya Bal Swasthya Karikram. Under that, treatment for congenital heart disease is free. Kerala implemented this in a program called Hridyam. We had a very energetic administrator in the government, Dr. Srihari. And in 2017, three private hospitals in Kerala were empaneled along with 3 government hospitals. So today, you suggested that every child should be examined. No, it is legally mandated that any baby born in the government setup, forget in the private, you have to do it anyway. Any baby born in the government setup has to have an SpO2 documented. The system is provided by the government and the result uploaded into a government computer system, which is verified from the capital. And there are district level organizers who are held responsible if a person or a child goes undetected or uncared for. This is working extremely well in Kerala. West Bengal has copied this and I hope it has started now. Maharashtra is starting it in a big way. I'm not sure about the Hindi heartland where the surgical facility is still poor, but certainly in Kerala and the South Indian states, this is working.
Well, thing is that I'm very happy to hear that Kerala has such a system, very systematized system. But you should understand that Kerala is
very small,
highly educated state,
yeah.
And you can't Kerala versus the average rest of the country is very different. And let me tell you an old told story that there was a time when Sardars in Punjab, they were asking for Khalistan, and there was a Khalistan movement going on. And then I call somehow, I call Ipan Koshi. Ipan Koshi is a friend of mine and is a cardiologist in Kochi now. So I said, no, these idiots, I don't know why they want a separate state. He said, no, they are right. He said, even Kerala should have a separate nation and Punjab should have a separate nation. Rest of the country is useless. he said, the Punjab is feeding the whole country with rice and wheat. And, we do so much thing for the rest of the country and the rest of the country does nothing for us. So anyway, that's in a light mood. But, like what has happened in past 20, 25 years, I came back to Delhi in 89 from UK. And what I have seen, though very positively, and it's a happy thing, that the healthcare infrastructure has developed much better in South India as compared to many of so-called Hindi heartland. What is that heartland? I don't understand. But like UP, Chhattisgarh, even Madhya Pradesh, even Punjab, so-called one of the very forward states, we don't have that kind of system even in Punjab to detect congenital heart disease and to treat these babies in time. It's very disappointing, but that's what is happening. But the thing is that somebody should people in Kerala, like people like you who are leaders in congenital heart disease in the country, they should talk to health ministry to apply these principles all over the country in all the states. I think that is what is badly needed.
Sir, you will be happy to know that Chhattisgarh started a Bal Hriday Suraksha Yojana in 2008. And again, the treatment is free since then to every child under 18. Initially, and that is how we copy this idea to cater services to 18 plus also. So initially, it started as a Bal Hriday Suraksha Yojana and in 2008. I have a different concern, sir, when we should close ASC in elderly and when we should leave ASC in elderly. Because we get 55 plus, 60 plus patients, 60 years plus or 55 years plus patient. So is it wise to, close those ASCs? or it is wise that we leave them as such? It's going to benefit.
Basically,
It's
Samit, that will
a
depend upon
nuanced
the
question, Smith.
left to right shunting and pulmonary artery pressure and the ratio of the systemic vascular resistance to the pulmonary vascular resistance. That
It's a closable ASD.
yeah, you have to see the overall advantage to the patient in the long term.
Right side is dilated and it's a
Yeah.
closable ASD. Maybe, most of the times they present with AF and then we pick up that they have ASD.
Right. Yeah, I think I think good case study done by a person who has knowledge of hemodynamics and congenital heart disease should be the dictum to decide about these patients. So what I do myself is, but I don't decide myself. I will always involve my pediatric cardiologist in these patients to decide what should be the best line of action.
We have your pediatric cardiologist here today as a speaker.
Smith, I had addressed this issue in some detail in the beginning of my talk. As to the first part of the question, there is data that in selected cases, it certainly helps the patient in terms of symptom relief and quality of life. It certainly should not be done to every patient that you see with an ASD and a good left to right shunt. You need to look at the comorbidities carefully and cardiac-wise critically evaluate the diastolic function. I would say it is mandatory to see the LVEDP with the device in place. And if you do that, and if you pre-treat the patient with appropriate therapy, which would include vasodilators and diuretics, then you can do benefit to this patient. And there is data for me personal and also large literature data to say that this is beneficial even when there is atrial fibrillation. In fact, one of the cases that I showed was where we put a LA appendage device and then close the ASD in a 65-year-old nomadic Bedouin Arab. So in selected cases, it certainly helps. On the lighter side, I must say that I have a 70-year-old lady who had a good improvement after ASD closure, because she had effort dyspnea before. She developed a CA colon and came and told me that she had absolutely no problem before I closed the ASD.
Yeah, but
Yes.
Suresh, I just want to make a point.
Yeah.
Can I make a point?
Yeah,
I
sure.
think congenital heart disease should basically come down to only infant unit program. I'm not talking about the fetal component because today fetal treatments are very few. But otherwise, if you want to make a difference with a large population of congenital heart disease, it has to be only infant unit program and preferably before 6 months of age. And I said pulse oximetry has been a game changer actually. You're detecting almost all the complex congenital heart disease. But of course, you're overdiagnosing because you're doing a pulse oximetry at 24 hours now. It should probably be done at around 72 hours, just before the child is discharged. And then you're likely to pick up all complex congenital heart disease who are maybe relatively asymptomatic at birth. Of course, those who are at birth, they are anyway sick and they will probably be suspected to have congenital. So I think infant unit program should be our national goal rather than 60 or 70-year-old or ASD closer at 20 years, 25 years. It doesn't make any difference to mortality. It may give you some consolation that you have done something good. But basically, they all have to be done by age of 2 years. All shunts by age of 2 years.
That's
All
the idea.
by 6 months or palliated at 3 months and if possible, palliation completed if possible by 5 years. This should be the general policy. And the government should probably have the infrastructure to deal with these problems, as Dr. Suresh Kumar said. Kerala already has it, that any newborn child is not orphaned. There is a system in the government which takes care of that child and sends them to various hospitals which are currently doing good infant unit programs. So I think Kerala is, of course, a little different. And I think the rest of the country may have to wait for maybe a couple of decades to come to this level.
Yeah, I think Jaganmohan, you said rightly. I mean, there should be some kind of clear-cut policy as a nation-wise that every child should have a examination at the age of 6 months or 1 year, whatever the pediatric cardiologists of the country advise, whether it's 6 months at 1 year. because it is very common to miss congenital heart disease when the child is born. Like my wife Neelam is a neonatologist, and believe me that neonatologists uh, they 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 don't have the real kind of capability to detect congenital heart disease in every patient, and practically it is not possible for every child born in this country to be examined by cardiologist. That is not possible. You have to understand that our country is kind of very funny, very amazing, very difficult, very simple, very interesting country. That you have states like Kerala, you have people like Suresh and Radhakrishnan in Delhi, and then you have people who don't know even ABC of congenital heart disease. Even cardiologists, let me tell you, cardiologists are very poor in general to diagnose congenital heart disease. Believe me, that any cardiologist who listens to the child below 2 or 3 years of age, they don't understand. At least I don't understand. I'm admitting that, and I just tell them that no, please go to a proper pediatric cardiologist. He will be better assessment for your condition. But unfortunately, that doesn't happen with everybody. Every cardiologist doesn't understand his own inadequacy, so that he can take an opinion from a proper pediatric cardiologist.
I think we owe, at least our generation owes a lot to Dr. Rohit Manoj.
Yeah. Younger generation is better, but the old generation had their own kind of ego question that I'm the biggest cardiologist in the world, so I know everything.
I always see hope, sir, because now, most of the deliveries, you don't see home deliveries anymore. Most of the deliveries are instituted at institutions.
Yeah, but I think I want to ask Suresh
One
that
says
I think the
would also
Pediatric Cardiology Association of India, they should have some interaction with the health ministry to make some kind of norms for the whole country rather than just limiting to Kerala or anything else. I think Suresh, you have a bigger responsibility for the country.
No, Claire, I want to respond to that. Actually, it is the initiative of the PCSI, which got, along with IEP, which got a list of congenital conditions listed to be mandatorily screened in the neonatal period.
Very
So
good.
there is a national program. The point is only Kerala went ahead and implemented it in all seriousness and brought down the infant mortality down from 12 to 6. The other states did not do that, partly because or mainly because they don't have surgical facility. Like Dr. Jagan pointed out, what makes the difference is neonatal and infant surgery. In terms of mortality, if you want to deal with congenital heart disease, it has to be neonatal and infant surgery. We see adult therapies because they exist and they come complicating something else. But the focus at a national level can only be on this. So there is a program already in existence. It is only the earnestness with which every individual state will implement it that will make the difference. I'm happy to say Dr. Smith saying that it is already there in Chhattisgarh. I know from because Kerala was involved in an interaction with West Bengal, that West Bengal was planning to start it, hopefully started. So maybe something is happening. It's certainly different from what it was 25 years ago.
It started, but now I think it's again stopped, sir. It was called Shishu Sati, and it had started, but
It
nowadays I
requires a
think
lot
they're
of
not doing.
political will, let me tell you, because
Yeah.
infant neonate congenital heart disease is spread around, equally around the population. While the congenital, the coronary heart disease and all those things are, sort of the well off and all those things. Here, it's equally distributed. So I think it doesn't
parents are
actually need a
generally poor.
political culture to look at it.
Sir,
Telling
if
you
I
that.
can, if I can interrupt, there is a question in the chat box.
Yeah,
If we
sure.
can just take that.
Yeah.
So Dr. Ardra is asking, in RV dependent coronary circulation, how did the child have a successful BD gland shunt?
Oh, there's nothing.
If
Actually,
I'm getting it right, yeah, Dr. Ardra, you can go ahead and talk also if you want. So the question is, in RV dependent circulation, how did the child have a successful BD gland shunt?
there's nothing preventing a RB-dependent coronary circulation from having a bidirectional gland. I've seen that in more than one instance. The problem comes when we are trying to decompress the RB. As long as you're not decompressing the RV, the child will do okay. But of course, the child can die independently because there is a coronary abnormality, and whatever you do, that coronary abnormality could turn out to be lethal. But otherwise, there is a fair chance that a child could survive the first few years of life on a bidirectional gland without much problem.
Yeah, the only contraindication for RV decompression is coronary, coronary, RV-dependent coronary circulation. The
So
contraindication for
about this,
decompressing that, you can bypass the RV and get your BDG or even Fontan probably, but they don't survive because of
Fontan
other
doesn't work.
problems.
Again, Fontan doesn't work.
Yeah.
By
So
Fontan,
they don't
the
survive
RV is
because
not
of
a
other
Philippian. So that wouldn't work.
so about suicidal, if we suddenly decompress the RV or decompress it completely at one go, there is a chance of the RV going suicidal. So
No,
how do
the
you
child
prevent
will
that?
die. There's no chance. If you decompress the RV in an RV dependent coronary circulation, child dies on the table.
Yeah.
Okay.
Anyway.
Even I had that. I couldn't understand that point about shunting in maybe. So you were saying that after doing the balloon pulmonary valvotomy,
Huh.
we also did a shunting
Why did you put a
of the duct,
ductal stent as well?
of the stenting of the duct. Yes, sir.
Why was it needed?
Yes, sir.
Oh, this is because in critical PS is a very different ball game from an older child with valva PS. In critical PS, you have a densely muscular RV. So simply because we have opened the RVUT, that RV will not take enough inflow immediately to maintain saturation. That will take weeks or months. So if you need to tide over that crisis period, which is done with either these days more often with a ductal stent or with a BT shunt.
Okay.
In fact,
Got
it
it.
may not completely recover. Many of these RVs will remain small, lifelong.
Yeah.
You
That
end up
depends
having
on
1.5 ventricle repair at a
yes.
later.
Yes.
Yeah, that's right. And yeah. Good.
Right. So about that left main occlusion, do you think that
Yes.
about that left main occlusion
Yeah.
in the severe aortic stenosis patient?
Yeah.
Do you think the coronaries were absolutely normal? The distal coronaries were showing some stenosis, maybe, and
No.
also bleeding abnormalities.
See how we reconstruct the situation. This child had a very tough initial surgery with a lot of oozing around the dacron graft. So a lot of what do you call it? Surgicel or surgical
Glue.
glue had been stuffed into the region around the aorta. What turned out to be lethal was the glue around the and the consequent fibrosis perhaps around the left main. What was happening to the distal coronary was not the life-threatening problem.
It was an extrinsic compression.
Yeah.
Yes, and maybe
We
the
have had
bleeding.
similar situations of extrinsic compression on left main by ASDs with severe pulmonary hypertension and PA dilatation.
Yes.
We have had one or two Eisenmengers which had ischemia demonstrated in the LAD territory. Very trickle of flow in the left main. We had to stent them. They survived the stenting and the LV dysfunction improved, but they died of Eisenmenger.
Yeah. But here we thought that we had done a very masterly intervention, and then the child died of a recurrent VF, a small bleeding triggering a hypotension. In a baby who had gone through this difficult situation, that was enough to tilt the balance.
But that was the sad ending for a excellent work.
Yes.
It was a GI bleed or any other bleed, sir?
What is it?
So, what was the source of that bleed? It was a diffuse bleed or a GI bleed or a particular focus of that bleed?
The child had a percutaneous cardiopulmonary bypass. So the child was being decannulated. And it's a very large, it's a 14 French cannula in a 45 kg child. So when the decannulation was being done, there was a small tear in the iliac artery. The surgeon quickly repaired it. But even though it was repaired, there is a time loss and a fluctuation of blood pressure. During this time, this all happened in over a very short period. During this period, the child arrested. They will respond to cardioversion, will come back. it kept going back and forth, and eventually the child succumbed. And by the time the child had diffuse bleeding also.
Right.
And mind you, the child was on heparin. The on cardiopulmonary bypass, which was decannulating, it was on heparin. We had waited for ACT to come below 200, but still under the effect of heparin.
Okay.
Just to emphasize that nothing can be taken lightly. You're pulling out a Cadillac can cause death. That's true, actually. You
Yeah.
had several complications, life-threatening ones, because of the work stenting, because we have put a 14 French sheath and we have landed in big troubles.
Yes, we see that in tower or structural cases also. Everything goes well, but the iliacs
Yes.
create problems. That is also right.
Dr. Suresh, just an opinion from you. What would be your advice to a mother or the parents if at the age of 12 to 14 weeks fetus, they discover a complex congenital heart disease, which may be difficult to treat completely. It may be palliated, but not treated, cured, or corrected completely. What would be your, or would you have some opinion on a particular condition, a different condition in another?
Yeah, I would say that it depends on the specific condition, that what is our understanding about the long-term prognosis of that condition with palliation, plus what is the economic and financial status of the family. For instance, if this is a laborer, you have a single ventricle, and you are saying that you could take the child through a 3-stage surgery, it may not be a good thing to do. In fact, there's an Indian Journal of Medical Ethics where I was asked to write an editorial on this topic. A single ventricle in a manual laborer family, what would be your recommendation when you are diagnosing in fetal echo? In that setting, I would closely probe how badly do they want to continue their pregnancy. And especially if the mother is young, it's much better for them to lose the child in an abortion than to develop bonding and lose the child a few years later. As against, I can remember a specific instance where a mother clearly said that if my child will live 10 years, I'll be happy with it. In fact, as Suresh said, there was a heterotaxy ventricle. They say this came not at the time of fetal echo, it was, but after delivery. When we said that continuing treatment may not be appropriate, she insisted on treating. So we did a BT shunt as a newborn, single ventricle pulmonary atresia, TAPVC. TAPVC repair with BT shunt. We did a Glenn. We did Fontaine completion. That boy lived 20 years. He was a literature postgraduate when he died. But the family accepted it. They all, and they're closely related to a good doctor friend of mine. So these type of instances come where we need to take the parents' wish into our plan. So there will not be one single answer to that question. The nuances will be the prognosis of the condition and the status of the family and the extent to which they will understand our discussion.
I think, Suresh, this is of course, very important question and very important topic in medicine, not only in congenital heart disease, but in any kind of even in adult disease. Where to put breaks, and how long you continue. For example, we treat patients who are elderly, 80 years old, and then he has a AF, he has got a kidney problem, he has a coronary artery disease, and how long you will continue. So I think this is very important and very sensitive part of medicine, which is never taught in books, and nobody can teach you actually. But I think there you need a lot of maturity, scientific maturity, a lot of humanistic attitude to talk to the family, to understand their ideas, their level of education. Usually, what I do is that I call the whole family whenever I am in this kind of situation. I said I don't want to talk to one person or two person. Get all the family, all the kind of sons and daughters and son-in-laws. एक बार आ जाओ मेरे पास मैं आपसे सबसे बात करूंगा. So then I explain them everything. These are the possibilities, and this is going to be the quality of life, and this is what you would like me to continue the medication, or you would like to de-escalate the therapy. Similarly, the situation in children. Children is even much more difficult because the parents they are highly emotional to the child, uh, particularly mother. The mother has kept that baby in the womb for 9 months, and they are really attached to that child. So it's a very tough job for, I think, a pediatric cardiologist to counsel these patients. But nevertheless, what you said is very right. If it's a poor laborer, I will put a break. I will tell them, don't treat this child. You're not going to go anywhere future, rather than that produce another child. But you have to individualize.
We should leave it to the parents to make the decision. We could only put the scientific component to them. I know that a laborer may not understand the depth of
No,
scientific
Jagan Mohan, you cannot,
seriousness,
in India, you
but I
cannot.
don't think we ourselves should weigh in this particular decision. Because I think this will come to the legal problems also in the future.
No,
I think the
what I
entire
do
thing
is
should be put across to the parents, because they'll be the decision makers, and it shall be only their decision what is to be done. I mean, we could only give only the complete scientific component and not the emotional and financial component.
you are
That
right,
is up
very
to them
right.
to
But let
decide.
me tell you one thing. Let me tell you one thing, Jagan Mohan. In India,
I agree
ultimately,
with you. I agree with you. But when
many
it comes
patients
to
want.
legal problems, if it comes to a legal issue, I think you might be put on the defensive. So I think you put everything on on a platter scientifically.
No,
No
I
emotional,
completely agree with you,
no
Jagan.
social, no economic component. You put only the scientific component to the parents, regardless of what they are, whether they can bring a lawyer or they can bring an educated relative, make a decision, get it written very clearly that only the scientific component has been explained to the parents and the decision has been entirely by them. I think this should
I
make
make a statement that we haven't made a recommendation on this. That we have explained, and in fact, we write a detailed statement in our report saying that the prognosis of this condition, of the both fetal and neonatal, has been explained to the family. We don't speak about continuation of pregnancy on paper. We don't recommend also. We tell them that it's your call.
That's right.
Yeah, that's right. You have to be very careful.
Yeah.
From
And
the medical point of view.
On a slightly lighter vein, just last week, we have done a TGA, an extraordinary TGA with a single right coronary, left coronary looping in front of the aorta. It's a marvel that the child was operated and is doing well. Very poor family.
Yeah,
The father met me. No, Jagan, listen to this. The father met me yesterday and said their original scanning had been done in a private center. He wants to sue the center. Can you support us?
Yeah, that's the thing.
I said,
That's
there is
correct.
no
That's
way.
what I'm telling you.
I said, I don't expect a scanning center to diagnose TGA.
Yes. Probably it's lucky that the patient is a TGA.
Yeah.
If it's a large single ventricle common, maybe
For us, certainly the
everybody will
legal
pick it up.
angle is paramount.
Yeah, Suresh, in the early 80s, we would miss TGA even in the neonatal period.
Yeah.
We had only an MO. We had only an MO echo at that time. I remember this. We used to suspect whether it is all systems of severe pulmonary hypertension with right to left shunt and all. This is a fact. But only we had MO echo that time. But today, I think things are different. We would probably not be missing many complex congenital heart disease in the first 3 days or 4 days of life. And I think we are looking, and only thing is we have to have the infrastructure to cater to them. I think they're still lacking, and we will probably require about 2 to 3 decades, let me tell you. It can't be overnight. It will have to be 2 to 3 decades before India can tell well.
Dragon Mohan, that may me and you may not be able to see that infrastructure.
Let us be pragmatic rather than, say, no, we'll get the infrastructure within 4 years, 5 years.
No, it's not
It's
possible.
not correct. That isn't right also. Not possible. It should be a slow process. There shouldn't be any redundancy also. You see, that is also important.
Sir, I am very optimistic because, we have everywhere now AIMS has come up. So every state has at least 1 or 2 AIMS. Only thing we need is a dedicated cardiologist, and they too now are being, they're coming in floods. So every place you have, well, every institute in every hospital in Raipur has 4 or 5 cardiologists. So the 5th one becomes an electrophysiologist, and this one becomes a pediatric cardiologist. So I'm hopeful that, in the next 5 years, maybe 10 years, the scene will be different. We have pediatric cardiology, DM pediatric cardiology now started at 2 places, 3 places. So it's
true.
not.
I think, you see, for the policy maker, infant mortality was the yardstick to go, how aggressive to go into some of these more difficult and financially and infrastructurally more demanding. So Kerala already had reached an infant mortality of 14 to 14, I think about 10, 15 years ago. And hence, this congenital heart disease came right in our front. While those who have infant mortality of average 30, I think the Indian average would have been now 25, they would find this very highly intense, infrastructure intensive, financially intensive, will take the back burner compared to, reducing the infant mortality by other means for other treatable conditions. I think that was the problem for the policymakers. I think they were looking on the infant mortality rate. I don't know. I mean, I just thought, because Kerala now it's, I think infant mortality is beyond below 10. I think Suresh said
6. 6.
6 to 7. Yeah, it will soon come to the level of the Far East, which is around 3%. Korea is 3%. I think I'm told. I mean 3 per thousand. I'm not 3%. 3 per thousand. Good. I think you've been.
I think we can conclude.
Yes, sir. Yes, sir. So, okay. So, thank you, Dr. Suresh Kumar, sir. All your talks are always vastly educative and bring out lots of questions and discussions. And we are really honored that whenever we ask you, you are always ready and you always share your vast experience with us openly and freely. And thank you, everyone else. Thank you, all the expert panelists, also for joining in, contributing with all the questions.
I want to thank Sujatya for calling me. It was nice to listen to Suresh.
Thank you so much, sir, for coming here. Dr. Suresh wanted you here, and we also
Jagan
wanted you
Mohan
here.
and Samit
And,
and new people.
Klesa, we wanted to see you.
Yeah.
You cannot see it.
I will complain that you are not visible.
I'm very poor in IT, but next time I'll make it sure that my camera is working.
Yeah, we want to see you.
Oh, sure,
Good.
I will next
Yes.
time.
Yeah, but listening to you is good.
Thank
It
you.
would have been
Thank you.
perfect if you also saw you. Good.
Thank you, Jagan. Thank you.
Take care. Yeah.
Okay.
Bye.
With that, sir, thank you, sir. We'll end this meeting and we'll, of course, upload this to YouTube whenever it's ready. Thank you, sir. Thank you. We'll
Thank you
conclude.
very much. Good night.
Good night.